I think I'm going to start. So,
We lost KGB. Where's Nick? Is he next door or is he confused?
last time, we came to know that as reviewing all the available literature out there, for ARDS, it's most important to keep your driving pressure and plateau pressure low. And the best way to achieve that is to keep the tidal volume low. And it's only after a tidal volume of 8 that volume itself becomes a problem. So most of the people will have barotrauma if you don't keep the pressure under control. But even with a driving pressure less than 20 and a plateau pressure less than 30, if your tidal volume is greater than 8.3, 8.6 in ARDS, you are going to have volume trauma. And then we keep the rate, if possible, less than 30 because that's atelect trauma. And then the best way to, until now, to actually manage PEEP is by the low table. And then we talked about, FiO2 should be less than 60% if possible. And, if your pH becomes less than 7.15, you can increase the tidal volume and for some time forget the plateau pressure thing, because here your acidosis becomes a bigger problem. Patient ventilator dysynchrony is the main reason why your plateau pressure might be normal, but your actual intra-alveolar pressure might be high because of the fact that you have to take pleural pressures into account. Okay? Now let's talk about non-ARDS. So the biggest study done is again a systematic review of all studies from inception who had patients without ARDS or acute lung injury and in whom low tidal volume was compared with high tidal volume. There were 1,411 studies, out of which 20 articles were of quality enough to be included, a total of 2,822 patients. And they compared tidal volumes 5 to 9 with 10 to 12. And it seems that even in non-ARDS patients, you can have volume trauma. And in this, the reason I put this slides in is because we are recording these lectures. And when you go through the lectures, you would want to stop at this page and basically go through it again and again. So 5 to 9 in reality is 4.27 to 8.63 ml per kg ideal body weight. And here in the conventional ventilation, the 95% of the people had 8.32 to 12.88. Okay, so it is 5 to 9 versus 10 to 12, but in reality it is 4 to 8 versus 8 to 12. So again, we have come to the same conclusion that somewhere between 8.3 and 8.5 is where volume trauma starts. Now the problem with randomized controlled trials is that they give you average results. So it will never tell you what will happen to Mr. Smith. It will tell you what will happen if 100 Mr. Smiths show up in your ICU. Okay? And therefore, a person can never have a mortality of 32%. A person is either dead or alive. It's 100 or 0. So that is the difference, that you will never know who will do bad with 8.63 or who will do bad with 4.27. Believe me, both are happening. Okay? So let's talk about, we talked about oxygenation. CO2 is easier. Basically, it's production versus elimination. That means if my CO2 is high, either I'm producing too much or I'm not eliminating enough. And on your ventilator, just like oxygen depends on FiO2 and PEEP, when you have a CO2 problem, you are looking at respiratory rate and tidal volume. All right. So let me ask you a question. Two twins come in, COPD or otherwise. They are twins, all right? They are exactly the same, identical twins. One is placed on a tidal volume of 600 and a rate of 10. Minute ventilation is 6 liters per minute. Other one is placed on tidal volume 300 and rate 20. Minute ventilation is 6 liters per minute. Will they have the same PCO2? Yes or no? Same minute ventilation, same PCO2, yes or no? Who's saying no? Okay, good. Everybody's saying no. Who will have a lower PCO2? Huh?
Only one have the higher tidal.
Twin 1 or twin 2, which will have a lower CO2? Who's saying 2? Okay, who's saying 1? Good job. Okay, they will not have the same PCO2 because of this phenomenon. You see, everybody has got a dead space. The physiologic dead space is 1 ml per centimeter of your height. Most people, it will be 150 to 180. Because you have the trachea and the bronchi and then 10 segmental, what you call airways on both sides, and they keep on dividing and dividing until about 14 divisions, 15 divisions is when you first start having bronchioles which are thin enough that oxygenation and carbon dioxide diffusion is taking place. Okay, and you have lost your tracheal cartilages. So what happens is that, okay, so 600 times rate 10, 150 is dead space. 600 minus 150, 450 reaches the alveoli and the respiratory bronchioles into 10. This person is getting 4.5 liters per minute alveolar ventilation. Okay. The other person is 300 into 20. 150 is dead space. So 150 reaches the alveoli into 20 is only 3 liters per minute. You will never find any combination for the same minute volume where the higher tidal volume, lower rate does not give you more alveolar ventilation than the lower tidal volume and higher rate. That is why when you have ARDS patients and you don't want to increase the plateau pressure, you have no other choice but to increase the rate. But once the rate becomes 30, 35, you have to increase the tidal volume. But in a non-ARDS patient, if you try to do this, you'll get into trouble because you'll always get more CO2 elimination. Go ahead.
Where's the 450 come from again?
600 is the okay, minus 150 dead space, maybe more in some people, right? So that is why your higher tidal volume and lower rate will always eliminate more CO2 than lower tidal volume and higher rate. Okay, and that is because of the dead space. If you look at PCO2, it is how much you produce, and then what is the respiratory rate you are giving, what is the tidal volume you are giving, and this ratio, 1 minus dead space over total tidal volume. Usually it is 0.3 in most human beings. If you are over-ventilating somebody, or if somebody has ARDS, somebody has other reasons why there is a space where blood is not meeting oxygen, blood is not meeting the alveoli, okay, and exchange is not happening. If your dead space is high, then that is a problem. You will have high CO2, okay? And therefore, always know that it is good to have, theoretical knowledge, but respiratory rate has a limit. Even in ARDS patients, maybe 30, maybe 35, stretching it. Tidal volume has a limit, maybe 8.5 cc per kg, after which it becomes dangerous. And minute ventilation has a limit because what starts happening is auto peeping. So you see your flow should always, and tidal volume should always come back to normal. So if somebody has a respiratory rate of 10 per minute, they are taking 6 seconds per breath, 1 second to take it in, 5 seconds to take it out, and all the tidal volume comes out. If somebody is having respiratory rate of 20 per minute, 3 seconds per breath, you take a breath, it doesn't come out fully, you take another one and another one and another one, and you start auto peeping. And the way to see whether auto peeping is happening is, number one, look at the flow, and the flow should come back to baseline, okay, after every exhalation. And number two, you do a end expiratory hold and then see what the pressure comes to, and that pressure should be equivalent to the PEEP that you are putting. So real story was, I was in Tulane and a respiratory therapist called me, and what was happening is that she and the resident were trying to get somebody's PCO2 down, and started with something like a pH of 7.3 and a CO2 level of 80. So they increased the respiratory rate, okay, from 15 to 20. Next one came pH of 7.2 and PCO2 of 90. So they increased the tidal volume. Next one was pH of 7.1 and 110. And at that time, they called me. What is happening? Auto-PEEP is happening. Okay, things are getting worse. All right. So I told them to take the patient off the ventilator. They refused to do so. I got into my Jeep. I was in the ICU in 13 minutes. I did get a camera ticket later because I ran 2 red lights. There was nobody there. It was 2 o'clock. And I had to physically fight the respiratory therapist because she was trying to not let me take the ventilator off. Then we took out the ventilator off, and you see a big exhalation that never stops. And when it does, now you go back to a respiratory rate of 10. Okay, so if somebody comes in with bad COPD, you want a I/A ratio of 1:4, 1:5. You want a respiratory rate of 10, and you want a tidal volume of 8.5 cc per kg, ideal body. All right, so ARDS and non-ARDS, there is a difference. And the other slide, when it comes in, is that you will see that, your flow, inspiratory, there's a flow, this is on volume control, flow comes out, exhalation, but before it meets the waveform, next step starts, and so on and so on. Okay, so beware of auto-PEEP. Just like you check plateau pressure, you should be checking for auto. Okay, all right. When auto-PEEP happens, you can do a few things. The best way to reduce auto-PEEP is to reduce the rate. Then you have your tidal volume and you get enough time to exhale, and then the new tidal volume, you get enough time to exhale. If you try decreasing the tidal volume, in response, the patient simply increases the respiratory rate, and the same thing happens again. Okay, so reduce the respiratory rate first and then the tidal volume. What else can you do? You can decrease the inspiratory time. In pressure control, instead of getting a tidal volume over 1 second, you might want to give it over less. The peak pressure will increase, but as long as this area remains the same, you will get the same CO2. So you are decreasing the inspiratory time. In volume control, the way to decrease the inspiratory time is to increase flow. Talk about that. Okay, so you increase the liters per minute that is coming in, so you reach your tidal volume at a smaller inspiratory interval, and so the E time becomes high. If nothing else, you have done a lot of things. You have even paralyzed the patient. The auto-PEEP remains. What will you do? Will you increase the PEEP or decrease the PEEP? Your PEEP, the PEEP you have set. Who is decreasing the PEEP? You will increase the PEEP. Okay. So what is happening is, the reason you will increase the PEEP, I will tell you exactly how much to increase the PEEP. How do I get this off? Hold on 1 second. All right. There is no eraser, I guess. Unfortunate. Anyway, so what is happening is that you have these alveoli which are trying to exhale through the bronchiole. And the reason they can't do that is because of collapse. The bronchioles collapse on you. So air is trapped behind. This happens in COPD patients, right? COPD patients, they try to exhale and the airways collapse. So what do? First thing, they do this. Why do they do this? Because they are trying to increase the space in their thorax. And the second thing they do is, what are they trying to do? They are trying to increase their auto-PEEP. So when you increase the PEEP to about 80%, of the auto PEEP. So if you have set the PEEP at 5 and the auto PEEP is telling you that the PEEP is becoming 10, you increase your PEEP to 8. If you do more, you'll reverse. Okay, air will start flowing the other side. But by doing that, you stent the airways open a little bit. You are exerting an opening pressure so that, like a pursed lip breathing, air can actually come out, opening the collapsed air. Okay. So if nothing else, you increase your PEEP to 80% of the auto PEEP and tolerate it. Okay.
You also make the triggering better.
Yes.
Yeah, I'm coming to that. Everybody got it? Okay. All right. So if the auto PEEP won't come down, no matter what you do, you reduce the minute ventilation by reducing the rate first. You can bronchodilate, you can raise the PEEP, you can accept the auto PEEP if it is not doing any issues. That brings us to modes of ventilation. Okay, and we'll discuss some modes of ventilation. Some specific to the ICU and some specific to you, some common between anesthesia and ICU people. When you are talking about modes of ventilation, you first have to see what triggers the ventilator, what is the target, and what stops the ventilator after every breath. Okay, so there are two ways of triggering the ventilator. Number one, if it is a control setting, even if the patient is not breathing, you will get a certain number of breaths that you have set and a volume of pressure that you have set. But if the patient is actually spontaneously breathing, they can start the breathing process by two ways. One is pressure triggered and one is flow triggered. Okay. In a pressure triggered breath, what happens is you can set it from -1 to -4, okay, centimeters of H2. So what is going on is, suppose if I have set a PEEP at 5, okay, so the PEEP is at 5. The patient, and suppose if I have set the trigger as -2 centimeter H2, the patient has to have a pull on the ventilator so that the pressure comes down to 3, which is 5 minus 2. And when it comes down to 3, it triggers the ventilator into giving a breath. Okay. The problem we don't want to necessarily use pressure triggering is that suppose if this very same patient has an auto PEEP of 3. So now the PEEP is 8. Okay, that's the auto PEEP. The patient will now have to pull down to 3, which will be a pull of -6 centimeter H2O, which is very difficult to do. So when you are using a pressure trigger, you have to understand that if somebody has an auto PEEP, they have to really pull to set the ventilator. That is why a flow trigger is easier. In a flow trigger, what happens is regardless of your auto PEEP, the ventilator has a basal flow rate that it uses to maintain. Okay. And all you have to do is change the flow rate a little bit. Okay. So if you are pulling with a flow of -1 to -6 liters per minute, it will trigger the ventilator. Okay. The problem with flow is that it can be too sensitive. So if you're using a flow of -1 in a paralyzed patient with aortic stenosis, for example, the hyperdynamic heart will be triggering it. Hiccups might be triggering it. Patient movement might be triggering it. Okay. So you have to make sure.
Water in the tube.
Water in the tube, the vibration of the water in the tube triggers it, right? So you have to make sure that when you are setting the flow, that the patient is only getting a breath when they need to. Once upon a time, I came in this ICU and I saw that somebody was on -3 pressure trigger. Okay. So I said, why? Because you wanted the respiratory rate to be 30 and the patient is breathing 50. So you look at the patient and no breath. Don't do that. Okay. Don't do that. You can't make it difficult for a patient to trigger a breath because you want the ventilator to be set in a certain way. All right. So we always try to adapt the ventilator to the patient and not the patient to the ventilator. So when you look at your patient, every time they make a respiratory effort, they should be getting a breath. Okay, otherwise it is very uncomfortable. So that's trigger. Okay. Now let's talk about the different modes. So you can set a pressure trigger or you can set a flow trigger. The first mode that I will talk about is pressure control. Okay. So in pressure control, and you guys can tell me if you're not being able to see this. Pressure control ventilation. You set a PEEP. Usually people will start with 5 for almost everybody. If somebody has a big abdomen or somebody is very obese or has some restriction, you go up. Okay, that's fine. So PEEP of 5 to 8. You give them 100% FiO2 to begin with, you can always come down. You give them a pressure control, a driving force of 15. You can always go up or down. And then you have a respiratory rate. Let's start with 20 and see what happens. Because we start here and we adjust. If somebody is on this setting, what will happen is that even if they are totally paralyzed and not breathing, every 3 seconds or so, inspiratory time, usually 1 second. So what happens here? Even if patient is not breathing, you are going to get for 1 second a pressure of 15 centimeter H2. Okay? And then it will repeat again. If a patient is spontaneously breathing, so even if they are not breathing, they are getting a rate of 20. But if the patient wants to breathe over 20, they just pull the trigger and again, they will get exactly the same pressure control for the same time. So it is time cycle. The target is pressure that you set and it will stop in 1 second because that's the inspiratory time that you have set. If somebody is breathing 20 times a minute, their I's to E ratio is 1:2. Inspiratory time of 1 second, and you are taking a breath every 3, so expiratory time of 2, 1:2. Okay, and that's a good place to start. And if it is auto peeping, you can either decrease the rate or decrease the inspiratory time. If they are getting too much volume, you decrease the pressure. If they are getting low volume, you increase the pressure. And in response to this, the patient will generate a flow. Okay, so as soon as the ventilator kicks in 15 of pressure, okay, initially the flow will be very high and then it will decrease, and at exhalation the flow will come down and you will have passive exhalation, and then the next breath starts and so on and so forth. Okay.
Well, the flow will be a decelerating ramp though.
Yes, sorry about that. Yeah, you're right. Because you are getting a pressure and initially you get a bigger volume. As your lungs fill up, the flow is going to look, I'll make it a different one. The flow is actually going to look something like this. Okay, a decelerating curve. Thank you so much. All right. And in response to that, you are going to generate a tidal volume, inhalation, exhalation, then the next inhalation, exhalation, and so on and so forth. The beauty about pressure control ventilation is that the patient can generate whatever tidal volume and flow they want to generate in that pressure limit. Okay, so it is a very comfortable mode. The downside of it is that depending on compliance, one person can generate a 700 tidal volume, the other person might not even get 200. So you are getting pressure that you are managing, that you have dictated, that this is the pressure you will get for this amount of time. And then you have to look at the tidal volume and check it every now and then to make sure that the pressure control is delivering the tidal volume and the minute ventilation you want the patient to generate. So if I am on a pressure control of 15 and I am generating a tidal volume of 500, I have a pneumothorax, suddenly it will be 200. I start developing ARDS, it will be 500, 400, 300, 200. Okay, so you got to keep a watch on that. The opposite of this is volume control.
Sorry, resistance too. Resistance, so if the resistance is high, Then the
Yeah.
tidal volume will also be decreased.
Okay?
So compliance and
resistance-
resistance.
If anything changes in the dynamic compliance, which will include the resistance or the static compliance of the patient, your volume will reduce. I totally agree. Okay. Now let's look at volume control. In volume control, okay, sorry. Might have to just add something here. Hold. Give me 1 second. Okay, much better. I'm going to give this one. Okay. In volume control ventilation, VCV, you again start with 100% FiO2, you can always go down. You start with a PEEP of 5, you can always go up. You give a respiratory rate, 20 is a good one to start, and you give a tidal volume. And here the tidal volume, let's say 450. No problem. Okay. What will happen here is that even if the patient is not breathing, when you look at the flow, even when the patient is not breathing, for 20 times a minute, the patient is going to get different kinds. I'll come to that. Patient is going to get a flow, and what stops the flow, 60 liters per minute, is that when they reach a tidal volume of 450, it stops and the patient exhales. This is when you use a square waveform, a constant flow. Okay? And 20 times a minute, the patient will do that. So you trigger either time triggered or patient triggered breath, you are going to get a constant flow for that amount of time that gives you a tidal volume of 450. There is a decelerating flow also that is better for people who are not COPD. Constant flow is better for COPD exacerbation for auto-peeping patients because it gives you the shortest inspiratory time for that amount of flow because the flow is constant. But when you are recruiting alveoli, you want the air to enter slowly so that it gets more distributed in a non-homogeneous lung. And you can use a waveform, a flow form, okay, that is a decelerating flow form in which what happens is that you get a high flow, and then as the lung fills up, the flow is going to decrease towards, sorry. So you are going to start with a high flow, and then the flow liters per minute keeps decreasing until you get to tidal volume 450, after which you exhale. Okay, so this is what a decelerating form looks like, maybe a little bit more comfortable for people who don't have the auto-peep problem. Okay, in response to the flow, you are going to generate a pressure. Okay, because as your lung fills up, the pressure will keep increasing until the flow stops, and then the pressure comes back to normal, and so on and so forth. And because of that, you are going to get volume, and you take the breath in, get the breath out, take the breath in, get the breath out. The problem with volume control ventilation, the good thing about it is that you have an assured tidal volume. That means as your compliance, whether it decreases or increases, the machine is going to put in 450 tidal volume no matter what you do. Okay? And if you want to breathe 30 or 40 times a minute, every time you trigger the breath, you are going to get 450. Okay? The way to change the inspiratory-expiratory ratio is to increase the flow. So if I give you a flow of 80 liters per minute, you will take less time to get the same tidal volume, but you are going to get a tidal volume of 450 until your pressures may increase so much that the alarms start ringing. But this is the way volume control works. It is an uncomfortable mode because of the fact that I've been breathing for a long time, and just because I got sick once and I came into your care, you are now basically telling me what is the liter per minute that I can take. And if I have air hunger and I want to take a breath at 80 liters per minute and you have set it at 60, I am going to have patient ventilator AC. Okay? So in pressure control, you set the pressure, you got to watch the volume. In volume control, you set the volume, you got to watch the pressure. So now you are checking plateau pressure, auto PEEP and all that stuff, okay? Because you got the volume, but now the pressure is the one that the patient dictates. So in order to, nobody uses volume control ventilation in the ICU. Does anybody use volume control ventilation?
I do.
Okay, I will say again.
Depends. Depends.
Oh,
It's not a hard and fast.
so Dr. Baloch said that she uses volume control ventilation. I think I will convince her that she does not use
I
volume
don't use
control
it
ventilation.
that often after talking to you all.
No, I will still convince you that you are not using volume control ventilation.
Okay.
Because of the problem with volume control and pressure control, somebody came up with adaptive pressure control ventilation. And in the company that we buy the ventilator from calls it PRVC. And PRVC
Or worse.
is not volume control.
It's not one pressure.
It is an adaptive pressure control ventilation. Now let me explain what an adaptive pressure control ventilation that they call PRVC, okay, and confuses everybody. What does that do? So in PRVC, again, you set, just like volume control, you are going to set PEEP, you are going to set FiO2, you are going to set respiratory rate, you are going to set tidal volume, and you are also going to tell the ventilator what inspiratory to expiratory time you want. Okay, suppose if I'm in the OR, 1:3. If there's somebody COPD and all that stuff, auto PEEPing, 1:4. If somebody is in ARDS, you start at 1:2. It's a restrictive disease. You want to keep the alveoli open. You want an increased inspiratory time to give the same volume with a low plateau pressure. So give it over a longer time. And people exhale very well because it's a restrictive lung disease. No problem in air going out. The problem is in air going in. In COPD, no problem air going in. Problem is in air going out. Got it? Okay. So in PRVC, what is happening? PRVC. Almost looks like volume control, doesn't it? But instead of this flow, it is pressure cycle. So just like pressure control ventilation, you are going to give, it is going to give when the time comes, either patient cycled or because of a respiratory rate of 20, every 3 seconds, it is going to give you, and if inspiratory to expiratory time is 1:3, it is 0.7 seconds inspiratory. For 0.7 seconds, it will give you a pressure. It will start with somewhere around 35. If you have set the alarm at 40, it will start at 35, right? And then it will stop in time. And in response to that, you will have a flow. And then it will calculate how much tidal volume did you get. And if the tidal volume is 400 and you have set 450, it will give you more pressure. And if the tidal volume is 600, it will give you less pressure. And every breath, it will adapt the pressure, or sometimes in some machines, it's every 3 breaths. It basically calculates how much you are getting, and the doctor said 450, and it adjusts the pressure accordingly. You can generate whatever flow you want. So it does not restrict flow. It gives you pressure for time, and you generate the tidal volume. The only difference is it's like pressure control with assured tidal volume. That's really what it is.
Like SIMB.
So that's different.
Yeah.
Yeah. You do not have on your machines, you have volume control and pressure control.
We have volume control, pressure control, volume guarantee.
Yes.
Would that matter?
Yes. So depending on the machines, pressure control volume, is it pressure control volume guarantee or is it volume control? Okay, pressure support. With volume.
SIMPCV,
Okay, got it. So it might do something of the same, okay? There is something called pressure support with assured volume, but what that does is it gives you a pressure support that you have set. But if the patient is not taking a volume of 450 in that breath, it goes into volume control and gives you the breath, okay? Something like that.
Yeah.
But yeah, the idea is the same. They call it with very different names.
So it's like pressure support when the patient triggers the breath. But when the patient is not triggering a breath, depending on your setting, it's gonna give either a pressure controlled breath or a volume controlled breath.
Okay, to assure a minute ventilation, okay? Yes, nobody likes it.
And
Is PRVC a full support mode of ventilation? Anybody? So if you put somebody on PRVC, are they getting full support? Because you have set tidal volume of 450, respiratory rate of 20. Okay? Depends. Depends. Because what happens is, suppose it gives me a pressure of 10 and I generate a tidal volume of 700. What will it do? It will decrease the pressure.
on your next.
I still take a tidal volume of 700. What will it do? It will decrease the pressure. So on PRVC, the only way to know how much the patient is doing and how much the machine is doing is to look at the peak or plateau pressure. Okay. Where did it go? There it is. Thank God. Thank God. This patient is on PRVC, and if you go into your what you call ICU right now, there are patients like this. Okay. The machine is doing nothing because the peak pressure is 9. The patient is doing everything. It won't go to negative. If it goes to a pressure control of 0 and you still take 700, it is not going to say, okay, I'm going to now put negative pressure. But the patient is doing everything. Okay.
It's torture.
You can also convert it to, say, press the mode and convert it to pressure support. And if the pressure support setting that the ventilator suggests is 20, then that is what the patient has been getting from the machine, 20. But if it suggests 3, then the machine is giving a pressure support of 20. So it can be full support or it can be torture, depending on how you set it, and also when you see the patient, is the patient trying to make a, is the patient working hard? That's what we need to see. Same way with volume control. They call it full support, but it might not be full support if you are giving a flow of 60 and the patient wants 80, or you are giving a tidal volume of 350 and the patient wants 425. The patient will take 425 if that's what his or her body is trying to tell. Okay, so this whole thing about full support and feeding and all that stuff, it does not matter if you are not paying attention to the patient and synchronizing the vent. Does that make sense? Okay.
The bottom line is PRVC is a terrible mode for anyone with air hunger. Okay, so people that you're putting on the ventilator, so you guys, everybody's paralyzed, right? So it doesn't really matter. But for us, we don't,
It's fine
we
for
don't,
you guys.
at least I don't paralyze people. I try not to paralyze people. So it's a terrible mode for somebody who, again, when they wake up, if they have air hunger, it's a terrible mode, right? Because it's not, you never want the patient to be working harder on the vent than they would on their own, right? So you have somebody who's sick, somebody with a severe metabolic acidosis, somebody with a lot of air hunger. PRVC is a terrible mode. Okay. Just remember PRVC, terrible. All you have to remember, right?
Like severe, like ARDS or like,
So-
or paralyzed, I mean, PRVC.
So PRVC was developed as a weaning mode, right? It's supposed to be auto weaning, right? So, and again, but again, like all the other weaning modes, it's lousy. But so it So because it would automatically decrease the support as the patient took over that work, right? But the problem is that a lot of times the patient's waking up from anesthesia, they're just happy to lay there and let the ventilator do the work, right? So it didn't really speed things up any. And again, it's somebody who does take over that work can become excessive, right? So again, so the default setting when they bring people up here is PRVC from the OR, right? But generally those patients aren't breathing, at least not breathing yet, right? And when they're ready to wean, we switch them to something else, right? We don't wean them on PRVC because it actually prolongs the process.
Good. So we all agree.
We all agree.
Okay. The next mode that, what you call surgeons and anesthesia people like a lot is this SIMV, right? Intermittent mandatory ventilation synchronized. What does that mean? So in SIMV, again, I've somehow got my eraser back. In SIMV, again, we set a PEEP, let's say 5, we can always increase it. We set a FiO2, let's say 100%, we can always decrease it. Okay? We give a respiratory rate, 20. And we can do pressure control or volume control, but let's say here we give a volume control of 450. Okay? What happens here is that even if the patient is dead, he or she is going to get 20 breaths, okay, per minute of flow that will give that guarantee that volume. If it is pressure control, you'll get 20 of pressure control for the time that you have set. But if the patient breathes on their own in between, they can take whatever breath they want to take, however they want to take it. It won't stop them from doing that. But unlike volume control and pressure control, the patient determines what is the breath they are going to take in between. Okay? If this was volume control, every time the patient triggered the ventilator, they would get exactly 450 tidal volume, right? So that way it makes sense. And the whole idea was that it was developed as a weaning mode that, hey, you know what, we are going to put somebody on tidal volume 450 for a rate of 20, but as they get better, the rate can keep coming down until they don't need. The problem is that people have been, suppose if I come in, I've been breathing for 48 years, I have not taken a break, I promise. Okay, some people do, I have not. Okay, so.
You might be at night.
You never know.
Okay, you're old.
Or the,
Yeah.
the Indian yogis who sort of like bury themselves in the sand for like, 9 months and all that stuff. Right? They might take a break. I have not taken a break from breathing. Okay? So people, when they are coming off the ventilator, most of them don't need this weaning stuff and all that stuff. You either recover, you can breathe. You have been breathing for a long time. Okay? The problem with SIMV is that the diaphragm does not know. So, okay, so this is intermittent mandatory ventilation. Why is it called SIMV? Because what it does is, okay, synchronize. Where does the synchronize come from? So let's say you are breathing on your own in between. Okay? So you are breathing on your own in between. And now it is time for the machine to give you the mandatory breath of 450. Right? So what would happen if it gives a breath here? It will be disaster. It will be very uncomfortable. So it actually waits when it is time. Okay, now it is time. It is time. I should be giving you another breath. It will wait for a few seconds here and there for you to take the next breath and give it to you. So that it is not every 3 seconds. It is 20 times a minute. It will try to, when it is time to give you a breath, it will try to synchronize it with your next inspiratory effort. Okay? But the diaphragm will never know whether this time I'm getting pressure support of 5 or 0, whatever you have set for the spontaneous breath, or I'm going to get 450. So when it is not ready for 450, it tries to fight it. And when it is ready for 450 and it's not getting it, it's a very uncomfortable mode. And therefore, the only time I really use SIMV once every 6 years or so is when? People might be different. When would you use SIMV?
I mean, any issues with the diaphragm, I'm thinking?
Chain Stokes breathing is the only time I use it, because what happens is the time when they are not breathing and their CO2 is going up, then they start breathing. I want to keep the CO2 swings a little bit down, so I add a SIMV of rate of 5 or something, so that the time when they are not breathing, they get 5, they get some volume. Okay, that is the only time I would actually use SIMV. It should really not exist as a mode. Okay, but
Those in-betweens when they're taking their own breath, if they're taking their own, but they're just not generating enough tidal volume, will it eventually kick in?
they can generate whatever they want. They could generate a balloon of tidal volume, doesn't matter.
So nowadays, usually it's SIMV plus pressure support, so their spontaneous breaths are supported, right? So,
So we can't
sure I'm
be
the only person
like
like
they're
like
like
that actually have used IMV, let alone SIMV, right? So again, the problem with IMV is that, again, that it was a set time interval, there was no patient flexibility, right? So synchronized IMV, again, tried to time to patient's efforts, waiting that interval, whatever that interval was, right? But at the beginning, there was no ventilator support in between those breaths. I mean, it allowed the patient to breathe spontaneously, but that didn't necessarily mean the patient was getting support from the ventilator in between those breaths. But nowadays, you would almost certainly dial in some pressure support for those to assist those spontaneous breaths. But you don't have to.
Yeah, you can choose the pressure support of 0. And you have to understand that a pressure support of 5 to 7, like that lady today, she got intubated with a PT tube of 7 millimeters. Okay, you need a pressure support of 7 to 8 just to overcome the resistance of that small tube. Okay, but yeah, you can choose to have pressure support of 0 if you want. Okay, so that's SIMV. Any questions about that?
Question. I mean, I understand what you're saying with SIMV, not sure change Stokes breathing, but SIMV, I'm assuming is different uses for us in OR, not like I've been using SIMV if someone's not paralyzed and or the end of the case. I would
Okay.
usually ask for pressure control, whatever, to SIMV pressure control. Is
What?
that they don't want to buck on the vent, they're gonna start kind of breathe over it if it's not synchronizing to them.
Okay, so if somebody is not paralyzed, you can go to pressure support. And if somebody is paralyzed, you put on pressure control. The SIMV is more for your mental well-being. It really does nothing
The
for,
physician, not the patient.
not the patient. It does nothing for the patient. Okay, because if I set SIMV, you know,
Yeah.
okay, so just wait for the patient to wake up and, yeah, okay.
Imagine that, for example, you have a group mate who is lazy and you have a project. So there are times that you wouldn't wait for your group mate to work, so you double work. You do all the job. That's what your diaphragm and your brain thinks when the patient is on SIMP. What happens is the diaphragm, your brain doesn't know when the machine is gonna give a breath. So every breath that it's gonna give is the same breath as expected, which causing diaphragmatic dysfunction, dysynchrony with the vent. And multiple studies have shown that it causes diaphragmatic damage to patients because the patient doesn't know exactly when the vent is gonna give a breath. So each breath that the patient is gonna breathe is the same effort, whether the machine is gonna breathe with him or he's gonna breathe by himself. Same effort.
Yeah, well, maybe actually a little bit different for you guys in the OR, right? Because again, they are waking up and they've had anesthesia, so their respiratory drive isn't stable yet, right? So the thing is, I can understand the rationale of using SIMV because it just gives you a little cushion while you wait for them to continue to wake up, right? So the thing is, you got to understand, again, narcotics are just the set point for CO2, right? So again, it takes a while for CO2 to rise. So again, if you switch somebody over, they might not take a breath for a while. I mean, usually I don't care, but I'm standing there, right? I don't do that, leave, right? Just like you guys, you're there, right? So you just have to have the patience to wait it out, right? And eventually their respiratory drive will kick in. And it may be, it takes a few minutes for it to achieve regularity, right? And a lot of times, what'll happen is they'll wake up, they'll take a big, huge breath, they'll blow their CO2 down, they'll stop breathing again, right? So it takes a while. You don't want to generally give them a whole lot of support because otherwise that situation will last longer. So if you don't give them that much support, their breaths are smaller, their CO2 plateaus, and they'll start to breathe, right? So
I don't think we are going to change that use, and that is not the idea here. Mostly because of the fact that the patient's stay on the ventilator is so much different in the ICU and not. In the ICU, we'll never use it. I don't think anesthesia will stop using it. And I
Yeah.
don't know if 5 minutes, 10 minutes really makes a difference. You know, but it's not a comfortable mode.
So the lungs are not diseased, and like when the patient is
Yeah.
having an elective surgery, so it's very different
Yeah.
in ICU than anesthesia. They're like totally
Except when
fine,
they
they
ask
were
me-
perfect patients.
Separate, yes.
So,
Okay. So the last is pressure support. Okay. It's a recovery mode, but hey, if I am intubating somebody just because of the fact that their airway is not controlled or their mental status has changed and they don't have COPD and they don't have ARDS, pressure support is the most natural way. Okay. So when I'm using it for actual ventilation and when I'm using it to do the liberation testing, the spontaneous breathing trial, it's two different things. Okay. So what happens here is that the patient has to be breathing. There is no set rate. In pressure support ventilation, you still do the 100% FiO2 and you still do the PEEP. And the only thing you have to do is pressure support. And you can choose. You can start with 10 and then let's see, we go up, we go down, doesn't matter. The patient has to generate the breath, whether volume trigger or pressure trigger. And one way to know immediately if your patient is on flow trigger or pressure trigger is to see whether this deflection happens on the pressure or the deflection happens in the flow. Okay. This patient, for example, where is it? Where is it? Where's my? This patient. Is this patient on a pressure trigger or a flow trigger? That sign is on the flow graph. This is a flow triggered ventilation. If it was pressure triggered, you would see the sign on that color difference on the, so this is a patient generated breath. If this was not patient generated, you will not see this purple color there. Okay, that's a timed breath. Okay, different ventilators being different, no problem. Where was I? Yeah, there you go. So when it triggers, all you have to do is to generate a flow and you will get the pressure of 10. And unlike pressure control, this is support. You stop the ventilator. So that means for that pressure, you are going to generate a flow. And then as your lung fills up, your inspiratory effort goes down. And when it reaches 25% of this peak flow, the ventilator will just stop. So with pressure support, you decide the tidal volume, you decide the inspiratory time as a patient, you decide how many breaths you want to take, and you decide the flow that you want to take it. Just like a normal patient breathing. Okay? So I could do 100 times, I could take one big breath and not breathe for the next 10 seconds. You can't paralyze a patient on this. The beauty about it, you don't even need much sedation. All you need is a little bit of pain control, fentanyl. Sometimes patients are anxious, a little bit of Versed, and patients are watching TV, writing stuff down, you know, the most comfortable mode there is. Whenever people are on pressure support, our respiratory therapists have this terrible habit of saying patient is on a wean. When the patient is on a wean, I'm very happy. And I go there and the patient is on a pressure support of 20. That is not okay. So I could make the flow trigger so easy. And the rise time, the number of milliseconds it takes for the pressure to build to 10, I could make it 0 immediately. So all my patient has to do is, and it gives, and then all you have to do is stop breathing and it stops. Okay? You could change this number. Suppose if somebody is auto peeping, which can happen on pressure support, I can make this number 35%. And then what will happen is, as soon as the patient has 35% of initial flow, the breath will stop. I could make it 15%. If I think that, the patient is having, difficulty maintaining an inspiration, not getting enough volume, I could make it 15%, in which case the patient will keep exhaling and then stop here. So with the pressure support, if your patient is getting a breath every time they make a respiratory movement, and they are not fighting to stop it, because if you have a pressure support of 30 and, I can stop, it's just they're blowing in, all right? Like long time ago, my job was to open and shut the door of the airplane when people were jumping. We had a small one. We had a small airplane, okay? And we decided that if I have a rope, then like Rambo, I might get out and then bang against the thing and get the whole plane down. So I didn't have a rope. I used to wear a parachute. And because the door was so small, I had to hang out and let people go. Okay, because I had to close the door. The pilot cannot. And when the plane is flying at 95, 100 miles, you open your mouth and that's it. You can't close it anymore. That's what pressure support can feel like. Okay. So you can increase it, decrease it. If the patient is breathing 24 times or less, getting a breath, looking happy, smiling across the tube, they are getting full support. Okay. Now, when you are using it for a spontaneous breathing trial, it is the simplest thing in the world. People have tried many different ways of liberating. And the problem with things like taking off the ventilator, letting them breathe through a tube, also called the T-tube and all that stuff, is that they are all more difficult than normal breathing, because if you have a tube in the trachea, by definition, the tube is smaller than the trachea. Okay. So when you are using it for, and with the pressure support ventilator, I know exactly the respiratory rate. I know exactly the tidal volume the patient is generating, because if I see that my patient is generating less and less tidal volume and increasing the rate, they are not ready yet. Okay. So if you have if you want to do a spontaneous breathing trial and you have a tube less than 7, you put them on pressure support 10 by 10, because remember, you need pressure support to help breathe in and you need PEEP to help the resistance breathing out. If it is a tube of 7, it is pressure support 8 by 8, just to compensate for the tube. If it is 7.5, it is 7 by 7. If it is 8 or 8.5, they do well on 5 by 5. And if the tube is 9 or greater, 0 by 5 is good enough. In anesthesia, I would do this for 15 minutes and the patient is good, you extubate. That's what you do, right? Because of the fact that critically ill patients have been on the ventilator for longer, some of them will show a late response of pulmonary edema, because as you reduce the pressure, the help that the heart gets from positive pressure, okay? Inhalation pressure helps the squeeze, and exhalation pressure, the PEEP, helps keep the volume, the blood venous return away from you, right? They will get a late failure and have pulmonary edema and what you call heart failure symptoms 2 hours later. So therefore, in the ICU, if you really want to have the lowest intubation rate, re-intubation rate, you just put them on a pressure support trial and you continue for 2 hours. And if they are still looking great, you extubate them. Okay? Is there any indices that helps you decide whether to wean a patient or not? Extubate.
Rapid shallow breathing index.
Okay. Rapid shallow breathing index is the only index that really works, but just remember, when you are on pressure support, it's not 105, it is 80.
80.
80. Because you are still on a ventilator, and therefore keep a low threshold. I never use indices because my indices is I look at the patient.
Yeah.
Okay, and if the patient is happy and the patient is doing good and the respiratory rate is less than 30 and the patient says, you can ask them actually,
Yeah.
are you, do you think you'll breathe? And go, yeah, take it out, take it out. That's it.
And also like
Okay.
patient with lung disease, they may not normally like breathe at 12 or 14 per breath per minute. They have like terrible lung disease. They usually breathe at 30. So like it's not as, again, like look at the patient and their history, not only the numbers.
The other things that I see, if the patient can raise their hand from their bed, they can breathe. Okay. Mental status, you have to really see because sometimes the only reason the person has a tube is because they are like, mental status is not good. And you know what works just as well? Nasal trumpet. Okay. So do not ventilate a patient because you don't know how to put a nasal trumpet in. Other thing that I always look at is secretions in the ICU. How much are the secretions? How much the respiratory therapist has to work? Because if they are thick secretions, mental status is bad, cough reflex is not there, patient cannot follow commands. When you extubate, you'll be in trouble. Last thing, cuff leak. You should also check it because why do people get reintubated? For OR, you take them out, they go into bronchospasm, okay, and then you have to put it back in, okay? So how do you check for cuff leak? You just remove the cuff and listen. And if that doesn't work, you can look at the ventilator and there should be at least a 50 cc difference between what is going in and what is coming out because some of it should be leak. Okay? All right? Oh, sorry. Okay, good. So patient ventilator asynchrony, I've been trying for at least 20 years. I could go 2 o'clock in any ICU in the world, there will be at least one patient who's struggling on the ventilator and everybody is relaxing because they are looking at 450 tidal volume, respiratory rate of 30, okay? And numbers look good, but the patient does not look good. And what will you do for this patient? You will immediately take them off PRVC and put them on pressure control, okay? Or even pressure support, depending on.
Yeah.
Depending, okay? All right. So, last thing, I promised you, I will tell you how it's set. Anyway, don't worry about it. It's 110. Thank you so much. Okay. Maybe we'll do that in one of the SIPs. How do you set PEEP in ARDS? Okay.